Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
Hello, I'm Karim Fizazi, the GTIC president and medical oncologist at Centre Oscar Lambret in Lille, France. Welcome to this program titled Latest Advances in Metastatic Hormone-Sensitive Prostate Cancer, an updated from Berlin 2025. In this program, we will cover some of the key clinical data in metastatic hormone-sensitive, which I also call castration-sensitive prostate cancer, that were presented in Berlin at this year's ESMO annual meeting, and this was actually a great ESMO. These data cover topics of rising importance in metastatic disease, and I've chosen them because they will likely impact our future treatment approach. But first, let's take a step back, if you don't mind. Let's look at our current treatment approach in metastatic hormone-sensitive disease. In the last years, say last 5 years or so, the most important angle most people have been taken for decision making was the volume definition, which is basically, do you have plus or minus 3 bone metastases? And then people would decide for example, a doublet hormonal therapy and radiation therapy for patients with low volume disease. And on the other hand, they would potentially decide for triplet systemic therapy, including docetaxel, for those patients with high volume disease. Actually, the last, let's say, 2 years showed us that things are more complicated than that. And indeed, probably the most important angle is not the volume thing, but more whether the patient has de novo metastatic disease versus recurrent metastatic disease. Recurrent disease, in many cases, is actually quite indolent, and how much we need intensification remains to be demonstrated. And we are more thinking about the escalation in some patients, potentially stereotactic radiation therapy, probably in a doublet, but how long should the doublet be? This remains unanswered, and clearly no docetaxel chemotherapy. On the other hand, patients with de novo disease keep dying from their disease, for most of them. And for probably most of these patients, intensification remains needed, and this may actually include triplet systemic therapy for most patients, regardless of the number of bone metastases, while radiation therapy is probably not improving overall survival, but it's preventing local progression. And again, this is independent from the number of metastases. So we should probably put less attention to the number of metastases and more attention to the recurrence versus de novo phenotype, and hopefully soon, and I'll come back to that in a second, the biology, which at the end of the day is more important. So currently, I think it's fair to say that we have a number of proven drugs, mostly the second generation AR pathway inhibitors, that all improve overall survival and progression-free survival. So we are using it. The question is whether we should use other agents, probably on top of these agents. This year at ASCO, for the first time, we saw the first trial dealing with precision medicine in metastatic hormone-sensitive disease. And this is the Amplitude phase 3 trial, looking at abiraterone plus prednisone plus or minus niraparib in patients with metastatic hormone-sensitive disease and HRR alterations, mostly BRCA alterations. We all know, I guess, that BRCA cancers are bad. And actually, this was shown also in patients with metastatic disease. No discussion. We also know very clearly that PARP inhibitors can help these patients when they have castration resistant disease. But the question was really, should we use a PARP inhibitor even earlier, basically at the diagnosis of metastatic disease, as we are starting other ADT and AR pathway inhibitor? And this is exactly the question Amplitude asked. The selected patients on a molecular ground, selecting only patients with HRR altered cancers, mostly again BRCA, but also CDK12, CHEK2, and some others. And patients were randomized in a one-to-one fashion to receive a doublet hormonal therapy plus or minus niraparib. RPFS was the primary endpoint, and it was clearly improved with a hazard ratio of approximately 0.63 for the overall HR population, but I think most importantly, 0.52 for patients with BRCA alterations, really showing us that those are the patients who benefit. It's really important. We're doubling basically or reducing by half the risk of progression or death. Now, very important also, this data came together with a benefit in terms of to symptomatic progression, because at the end of the day, RPFS is a registrational endpoint, but it's not really something we're measuring in the clinic, and it's not directly measuring the benefit of a given treatment to all the patients. But time to symptoms is obviously important to patients, as of course is overall survival. So we are actually now waiting for longer follow-up for this patient to see whether overall survival is also improved. At this point of time, there is a clear trend, but I'm actually quite confident that indeed we will improve overall survival with a PARP inhibitor when used early in the course of the disease. Now, this is not the only phase 3 trial for PARP inhibitors. We're waiting for at least 2 other phase 3 trials, maybe to read out or start reading out next year. So let's tune. I think this is really a very important path for research. Now, the second precision medicine trial actually was shown here at ESMO in Berlin, and that's Capitello 281. That's a phase 3 trial of capivasertib plus abiraterone versus abiraterone alone, actually, with prednisone in patients with PTEN deficient de novo metastatic hormone-sensitive disease. Again, as we all know, in proficient cancers, the androgen receptor is the main driver of a disease, of course. But actually, in approximately a fourth of all the patients, PTEN is lost. And in these patients, there is an additional proliferative pathway, which is a PI3 AKT pathway, that really drives the disease, actually quite independent of the AR. Also, we know that PTEN deficiency is associated with poor outcomes. So it's tempting, of course, to target both the AKT pathway and the AR pathway at the same time to try to get more benefit to all the patients when they have those alterations, such as PTEN deficiency. And this was previously suggested in mCRPC with another drug called ipatasertib. So the design of Capitello 281 is as follows. We selected patients with metastatic disease and PTEN deficiency, which was defined as greater than 90% of viable malignant cells with no specific cytoplasmic staining by immunohistochemistry. And there's actually quite great correlation between this and PTEN loss by NGS. We had to screen greater than 6,000 men to randomize slightly higher than 1,000 in the trial. And this is because only 25% of these patients have PTEN deficiency. So again, 1,012 patients were randomized on a one-to-one fashion to receive abiraterone, prednisone, and ADT, plus or minus capivasertib. Primary endpoint was RPFS, secondary endpoint, the main one, overall survival. This population is obviously a population of men with bad cancers. They have high volume disease, high risk disease, high Gleason score, everything, tend to show that this is aggressive disease. The trial is positive by its primary endpoint, and the hazard ratio is 0.81 for radiographic progression-free survival. So in other words, a 19% reduction in the risk of progression or death. And for those of you who like medians, this translated in a 7.5-month absolute difference in median from about 2 years in the control arm, again highlighting how aggressive are those cancers, to up to more than 33 months in the experimental arm. In pre-specified subgroup, we didn't really show differences. All patients in this trial tend to benefit by clinical factors. No real important parameter to take in consideration there. And then when it comes to secondary endpoint, we had a hierarchical testing procedure looking first at overall survival, which is just too early as we're speaking. And so we had to stop the formal testing for other endpoints. Now, having said that, during the time course of a trial, data emerged from another trial with ipatasertib in mCRPC, suggesting clearly that the higher the PTEN is deficient, the higher the benefit we might see from AKT inhibition. So based on this data, and also on preclinical data achieved with capivasertib this time, we decided to also look in the trial at this data of PTEN, the degree of PTEN deficiency, if you will. What we actually found was that, as I said before, for patients in the overall trial population, so those with greater than 90% PTEN loss, the reduction in the risk of rPFS or radiographic progression or death is approximately 19%. But actually, the greater the PTEN deficiency, the greater this benefit. And for those with a PTEN loss, or complete PTEN loss, if you will, so 100%, the hazard ratio is less than 0.7. So that appears to be an important parameter to take into consideration in the future. What we saw for rPFS was also seen by overall survival. So again, for patients with a cutoff of 100%, so complete PTEN loss, hazard ratio for overall survival is 0.77 and no longer only 0.9 in the overall population of a trial. Same phenomenon for secondary endpoints such as symptomatic skeletal event-free survival, time to castration resistance, time to PSA progression. The higher the PTEN deficiency, the greater the benefit from the combination treatment. Now, regarding safety, we basically saw what we expected to see based on previous experience with capivasertib in prostate cancer, but also in breast cancer. So, for example, the 3 or 4 typical side effects we're seeing with the combo includes diarrhea, approximately 52%, hyperglycemia, rash, and anemia. Having said that, side effects that are typical of abiraterone and prednisone, such as hypokalemia, hypertension, or transaminase increase, are really even between the treatment arms. So this trial is positive, CAPItello 281, by its primary endpoint, and this is also supported by secondary endpoint. It probably remains too early to say what exact benefit patients will derive from this approach. We need a longer follow-up. These patients live longer than just a year and a half, which is the current median follow-up. And probably the question will be how much PTEN deficiency we want to see to accept or to show the benefit. Now, another phase 3 trial was shown at the Congress. It's called PSMA Edition. And this is the first phase 3 trial combining lutetium PSMA and B hormonal therapy in metastatic disease. I guess you're all aware of lutetium PSMA, which is a radioligand targeting PSMA, which is transmembrane protein. The trial was quite straightforward in its design. Eligible patients included patients with metastatic disease, either relapse or de novo. They had to have at least one PSMA positive disease by gallium PET, and they were randomized to receive the hormonal therapy with a second generation AR pathway inhibitor with or without 6 cycles of lutetium PSMA. RPFS was the primary endpoint and crossover was allowed. So what we saw at the Congress was second interim RPFS and a longer follow-up is planned. I guess the baseline characteristics are really as you expected it for a metastatic hormone-sensitive population. We had approximately half patients with de novo disease and half patients with relapse disease, showing that this is a more favorable prognostic population as compared to what I just described to you with Capitello. Again, here in this trial, RPFS, which is the primary endpoint, was significantly improved with a 28% reduction in the risk. The median are not reached at this point, again, highlighting that this is a better prognostic population. We didn't see a real difference between subgroups of note. Data regarding SUV mean or any way to assess PSMA expression were not presented at the Congress, so hopefully this will be shown later on, and I guess this will be important. But with regards to clinical parameters, we didn't really see main differences. Overall survival is clearly too early to say. The hazard ratio for overall survival is 0.84, but really the curves mostly are confounded. Regarding safety, we basically saw here again what we were expecting, mostly hematological toxicity, but this is not nothing, 44% versus 20%, including anemia, neutropenia, and thrombocytopenia. Some grade 3 or 4, for example, 5% grade 3 or 4 anemia versus 3%. Also, a slight excess in renal effect and dry eyes, but most importantly, the number one side effect was dry mouth, with approximately half of the patients reporting some degree of dry mouth versus only 4% in the control arm. So this is, of course, an important side effect clinically. And this may explain why we don't really see improvement in time to worsening in quality of life or pain. The curves are mostly confounded, and actually, if anything, the lutetium PSMA is a little worse in terms of quality of life, and probably again this reflects the safety profile of the drug. So trial is positive again by its primary endpoint, but we don't really see at this point any overall survival benefit or any quality of life benefit, meaning that this is again probably too early to include this new treatment in our treatment paradigm. We need probably a clearer demonstration and a longer follow-up to make sure that we're truly impacting the right way all the patients. And more generally, I think this is 2025 is really the year where we're heading towards treatment personalization for metastatic hormone-sensitive disease. You've heard about PARP inhibitors, about AKT inhibitors, about PSMA targeting. Probably more is coming. We already know that in CRPC, HK2 or STIP1, B7H3, and of course VAR remains very important target for treatment. So I'm really confident that very soon we will actually assess the cancer at a molecular level and make a decision based on this. But again, this year is really the in-between year when we're moving towards this, and these are the 3 trials on this path. With this, I'd like to thank you very much for participating in this activity. Please complete the evaluation forms, and again, a big thank you.